So let's start with ENT, and we'll start with hearing loss, and in this case, sudden hearing loss. And there's some very important factors in sudden hearing loss. First of all, it's usually not very sudden. And the other thing is, the definition is that you have to lose 3 frequencies, and it has to be considered sudden within 72 hours. Your emergency physicians, I don't think 72 hours is very sudden. It's like, what? You know, like, okay. So within 72 hours, 3 frequencies and 30 decibels is considered sudden hearing loss. It's usually unilateral, and about 1/3 of people will wake up saying, hey, I can't hear. Sometimes it's involved tinnitus and vertigo, but not usually. There's a whole bunch of tests you can do to try to figure out sudden hearing loss, but it'll take more information than this to direct actually your investigations. So we're going to go through some of those things. So if it looks viral or if it looks infectious in some way, if they come in with big chipmunk cheeks and you're going, hey, maybe that's mumps causing their sudden hearing loss. If they have a big rash down cranial nerve 8, zoster, right? Viral could be causing that sudden hearing loss. Mono, Epstein-Barr virus can do that as well. Hematological reasons, I mean, we were talking about sickle cell earlier in the afternoon. You get some sludging stuff going through there. That can lead to sudden hearing loss. Metabolic, your sugar's really high, your lipids are really high. That can cause sudden hearing loss. And then the rheumatological ones, that one with temporal arteritis, I think that goes back to that sludging, thick vessels there that can cause hearing loss. And then a bunch of others like a blast injury, noise, otitis media. There's one down there, acoustic neuroma. I just like saying schwannoma. It just, you know, like it's right up there with Ludwig's angina. It's just one of those words you want to say, you don't want to have it, but schwannoma. Oh, that sounds nice. All right, so here is that schwannoma and acoustic neuroma. And interesting, I just had a case of Bell's palsy, not personally, but I had a case of Bell palsy recently, and I had a resident training with me, and the resident came up to me and said, I really don't understand. You know, they look like classic Bell, a peripheral nerve, 7th nerve palsy. They can't move that side of their forehead, that side of their face is drooping, but they're complaining of vertigo and some hearing loss. And if you know the anatomy, that 8 and 7 travel through that same bony architecture. If you get swelling and pressure on 7, that's going to hurt 8. And if 8 is swollen, right, with an acoustic neuroma, a schwannoma, that can present like a Bell palsy. All right, and it's because of the neuroanatomy there. It just happened recently. All right, sudden hearing loss. Well, ototoxic drugs can do this, and we've got a number of them listed there. We don't usually give furosemide in, hundreds of milligrams, but that could cause it. Salicylate toxicity. Again, I remember a great case with a handover and someone saying, hey, this patient, this woman, in fact, was complaining of tinnitus, hearing loss, and was acting a little strange. And it was delirium. And she had had some bad migraines. She was up at the cottage. I was at this critical access hospital. She thought she was taking ibuprofen, and what she was taking was like 800, 1,000 milligrams of aspirin over and over and over again, getting salicylate toxicity. You used to see this a long time ago before everybody sort of moved on from aspirin to other NSAIDs. That was an interesting case. The aminoglycosides, and there's just a reminder, anything that I really want you to remember, I put in red there, and that's just a reminder that vancomycin isn't one of the mycins. It isn't an aminoglycoside mycin like erythromycin and neomycin. Even though it sounds like it is not. So you can see how reading through a test question, and they list all these things, and they say which one wouldn't. That is not an aminoglycoside causing ototoxicity. And of course, chemo, and then conduction delays. And so you can have something obstructed in your canal, right? And it's usually wax, right? But other things can be stuck in the ear canal as well. My grandmother always said nothing bigger than this goes in your ear, right? And so you see right on the Q-tip box it says don't put in your ear. And yet how many times do we see people blocked canals because of Q-tips and things like that? All right, this side just reminds me that if somebody comes in and says, hey, my ear's really hurting, it can be a lot of different things referred to the ear. everything from cranial nerves to cervical nerve roots to other issues. And so here I've got listed some of the cranial nerves and cervical nerve roots that can do it, but it certainly can be dental. You can have malocclusions, you can have TMJ problems, you can have dental abscesses. And then things like infectious tonsillitis can give you ear pain. Otitis media, of course, can, mastitis, and other things. But let's get on to some specific ones. Does anybody know the history that usually accompanies this injury? I was minding my own business and these two guys jumped me. Or I was having a nice Chardonnay with friends at book club. Is this the kind of injury you see? No, the auricular hematoma is usually due to a direct blow to the side of the head, and it causes blood to accumulate right next to the cartilage. And the reason that's important is if you've got cartilage and you've got blood, cartilage loses, right? So you need to IND this and put a pressure dressing on it, or you develop, thank you, say it with me, yes. And so you'll see this in, the mixed martial arts. You'll see this in rugby players. They don't wear those helmets. Sometimes soccer players are going up to head a ball and they collide and they get a shoulder to an ear and things like that. Don't often see it in hockey and football because the ears are covered. Now, perichondritis is different though. And if you look at this image and compare it to this image, right, it's a little pink and swollen. But with this image, it's a darker red, but notice how it spares the earlobe. And that's how you make that distinction. That and, be hot, fevered, and pain, potentially fevered. And so you get this really, really red, angry-looking earlobe, and it's where the cartilage and the skin meet that get the infection. And because you don't have any cartilage down here, it usually is spared and it'll be pale. Now, you see this with a lot of piercings, right? And so people used to just pierce this, right? They'd have a little stud and stuff like that. Now I walk in there and it looks like a radial tire. There's all now maybe it's just I'm getting old and cranky, but there's all these studs. The ones that really impress me, they've got these bars, right? Like these harpoons that go through the ear, but they get more into it. They've got a harpoon that goes from there to their nose with a chain in between. What does that tempt us to do? Don't you want to just pull the chain? I mean, it's my inside voice saying, I just want to pull that. Not in my house, young man. Those are my dad voices coming out. But yeah, and so we'll see it with a lot of piercings. And I just saw on my Twitter feed, and I don't know if it was true or not, people are putting studs here, studs right on the bridge of their nose up here, so they can put bifocals on when they need them. Clip. What could go wrong? All right, so anyways, the treatment for this, because it's going to be what infection? When you have a rubberized substance and water together, Pseudomonas, Pseudomonas, Pseudomonas. Rubber, plastic, and water, cartilage, you get Pseudomonas. So anti-pseudomonal coverage, Cipro. All right, how about perforation? You can have barotrauma. So that's going up really quickly and going down really quickly with the eustachian tube being that venting tube, trying to control that pressure, and it can pop it, and you can rupture your eardrum. Of course, you can have Q-tips put in there. I like the people that don't use Q-tips, and maybe they're similar people to you. Oh, that stick looks good. I think I'll get my earwax out. Now, if they're a bit more sophisticated, they've got those nice ballpoint pens that they stick in there and dig around in their ear, or a bobby pin, or a paper clip. So any of those things, of course, can rupture your eardrum. Infections, we see that. Usually the child has been screaming, and then they have relief when it ruptures because it's an abscess popping, and they're like, ah. Now their ear's all wet, and they can't hear, but they feel better that way. So for perforations, if they say, which part of the anatomy could perforate most likely? And you're like, but it's so tiny, it's so small. Really, I need to know that? It's the pars tensa, which is the inferior, the bottom part, and the anterior part, usually ruptures, because it's the thinnest. Now, if it's penetrating trauma, we want to get those in to be seen. So if you have a water blast injury, like you're water skiing and you fall on the side of your head and you're getting water injected and it ruptures your eardrum, we want those people to see early. If those people are dragging that stick and cleaning out the wax, that'd probably higher risk for infection to be seen earlier. But if it's another non-traumatic injury, then not necessary. And they usually close on their own, and they don't necessarily need antibiotics. It depends on why it ruptured in the first place. And if you're going to go with antibiotics, topical or systemic, all right? If it's otitis media that's ruptured, we've actually got good data that topical is better. So the topical antibiotics are better than systemic antibiotics for children that have ruptured their tympanic membrane. There's a chronic perforation, and that's the Tars Penza that's ruptured. It's in the bottom part, the inferior, and the anterior part, and you can tell it's chronic because it's smooth-edged. And here's the study about drainage tubes. So 5 years ago in the New England Journal of Medicine, completely reasonable to be on the exam because there's always a lag between, really solid evidence and it showing up on the definitive exam for you guys to know. But if you've got a question about otitis media and they give you some options, and one of them is oral, sort of amoxiclav. In this case, they compared amoxiclav orally to a topical antibiotic with a steroid in it. So they compared amoxicillin with diarrhea, because that's what I refer to amoxiclav as, and a topical agent, and they found that the topical agent won out, right? It was more efficacious, and there was less side effects if you use topical. And so that's the key for this. And it's usually some Ciprodex or something like that, so it's a fluoroquinolone plus a steroid. Otitis externa can get worse than that, and you can get into malignant external otitis, and then you are going to need something more systemic, because if they have systemic symptoms, or those drops aren't even going to fit in there because it's completely closed up, then you are going to have to go systemic. You see this more often with, this isn't just a middle ear infection that's ruptured, this is an external otitis, and so getting that antibiotics in there is going to take oral as opposed to topical if it's really bad like this. And again, Pseudomonas, okay? And so you're going to be looking at fluoroquinolones. This wouldn't be treated with topical, this would be oral. And then otitis media, a lot of ink has been spilt on this. Still questions that get asked. What's the most common organism? Viral. What's the most common bacteria, though, is strep. Strep pneumo, followed by H. flu, and then M. catarrhalis. So if you read the question quickly, you might go, oh, it's strep pneumo. But if they ask you what's the most common cause of an otitis media, it's viral. If they define it as what's the most common bacterial cause of otitis media, it's strep pneumo. And we all see this, bulging eardrum and stuff like that. And it can lead to some badness. There is a bullous myringitis. Now, bullous myringitis usually follows a respiratory infection. The bottom there, I've just got that little thing in red there. They used to think, that's a red flag for mycoplasma. Actually, it didn't pan out. Serous otitis, or a glue ear, is when you've successfully treated the otitis media, and now they've got all that debris and thick fluid in there. And the reason that's important is if it's in a young child during their acquisition of language, it can interfere with that. And that's one of the indications that the ENT use for putting in venting tubes. So if they end up with a glue ear, fluid behind the eardrum, usually following an otitis media in a young child, that might be an indication for venting tubes by the ENT because of language acquisition. If your hearing's down and you're in that peak age where you're acquiring language, that could cause a problem if you can't hear very well. So important. A cholesteatoma, though, this is a chronic perforation, so you look in that and you go, okay, the Tars Penza is gone, and you look back to see the ossicles and you go, ew, that looks gross. And it actually smells gross too. And so this is one of those reasons that you need to actually get your friendly neighborhood ENT to see these ones quickly, because it can destroy the bone in there. So that's called a cholesteatoma. So if they give you a picture like that, you're like, that's not a Q-tip back in behind the pars tensa. Okay? That is a cholesteatoma. All right, that's it for that part. Now we're going to move on to vertigo. And don't you love that? Isn't that the next case on the board and you go, weak and dizzy? Sign me up. Do you know that back in, the 80s, early 90s, every 5 to 10 years they get consultants that come through the hospital and tell us how we're going to do our job better with flow, right? And it used to be Well, the new ones now are, they've got these automotive sort of models that you can do, and these nobody owns a bed, and there's all these different things. Well, back when I was in my residency, the big thing was to put a fish tank in the waiting room, because then people wouldn't think they're waiting as long, I guess. Now they have TVs and things like that. Everybody's got their own little screen, right? But they put fish, and I remember this one hospital put in this beautiful saltwater tank, and they had these beautiful fish that they put in there, and they had a naming contest. Do you know what the two fish were named? Weak and dizzy. All right, so peripheral versus central, and this is the big dichotomous sort of thing that we try to tease out when somebody comes in and says, I'm dizzy, I'm vertiginous. They usually don't say that. Okay, so central versus peripheral. So peripheral is usually very sudden on onset, and it can be intense spinning. And it comes and goes, and it tends to be positional, usually makes them sick to their stomach, but it fatigues, it goes away. That's the intermittent nature of it. Now, you may or may not have some hearing loss and tinnitus. You may have some abnormal tympanic membrane, but that's peripheral. Central, in contrast, is usually slow on onset. It's central, and it's something slowly growing, like a tumor, that's interfering with your balance. And so it doesn't come on suddenly, and it's less intense, and it seems to be constant. And when you look at the nystagmus, this is the key. If you've got peripheral vertigo, you have horizontal nystagmus, and I'm not too worried, because the most common cause of that is BPPV, right? And that's not life-threatening. And so if somebody's doing this, I'm not worried, right? Horizontal nystagmus. If they're doing this constantly in front of me, vertical nystagmus, then I'm worried, because this suggests a more central cause. All right, so this is the most common. So, like 90 to 95%. If you just walked in the room and go, oh, yeah, I think it's BPV, and walked out, you'd be right 90% of the time. But we have to be right more than that. We have to have a less than 1% miss rate. And so for BPPV, the key to these things are, people say, it hits me quickly, I turn my head a certain way, or I'm in bed and I roll over. It's really intense on onset, and when you test them, they get this very quick horizontal, sometimes a little rotational component to it, but horizontal nystagmus, and then it fatigues. There may be a delay in onset, right? So when you put them in the position, when we talk about the Hallpike maneuver, and you put them in the position, you watch them, watch them, watch them. I usually have a resident or a nurse standing, and there it is, boom, 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 boom. The patient wants to throw up. That's why I wear rubber shoes on shift. They go boom, 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 boom. And then it fatigues, right? That tells you peripheral, okay? And so here's the Dix-Hallpike maneuver. I'm not going to run through the Dix-Hallpike maneuver. There's YouTube videos. You know that the patient's sitting up, you turn their head, you drop them, you turn them over, you roll them onto the other side, you sit them up again. All right? It's rolling the rocks around in the head because the otolith organs, those little crystals, have fallen out of the spot that they're supposed to be. And there's the Epley maneuver, okay? And there's these great things that you can print off the internet, and I send people home with exercises if the Epley maneuver doesn't work. The Epley maneuver works if you've got BPPV. It works about 50% of the time, which isn't bad considering we're not using some fancy instrument. We're not doing surgery. We're not giving them some expensive medicine. You're just doing this maneuver with them. They think you're like the amazing Kresge when they stand up and they can walk and they don't have dizziness anymore. It's pretty incredible, but it doesn't work all the time. It's more like a 50-50 thing. So other things that can cause peripheral vertigo is vestibular neuronitis. It used to be called vestibular neuritis. It's an acute onset, like most of these peripheral ones are. It's acute and it's intense. We've got viral question mark, because we just throw it must be a virus, right? It must be viral, all right? It can last days to weeks, nausea and vomiting, so it can be fairly intense, changing of the head position, but it's limited to your balance. It's limited to the vestibular system, right? It doesn't involve tinnitus, and it doesn't involve hearing loss. Now, labyrinthitis, you usually get hearing symptoms with it. Again, an infection of the labyrinth could be as a result of ototoxic drugs. We can throw out viral there for you too. It could be due to a virus. Look for otitis media, look for mastoiditis. But they get vestibular and hearing symptoms. So we're going from the one, neuronitis, to labyrinthitis. So you're going from vertigo to vertigo plus hearing symptoms. Vertigo, hearing symptoms, and tinnitus is Meniere's. Okay, so that's the progression. So we're going from neuronitis, which is just the vertigo, and then you've got labyrinthitis, which throws on the tinnitus on top of the vertigo, and then you get the trifecta, Meniere's disease. Okay, usually unilateral, excessive endolength production, tinnitus, vertigo, and progressive hearing loss. This fullness, this pressure, and they can last hours, these attacks, as opposed to BPPV, which is usually short on acting and they turn and it fatigues. And it can last for weeks to months that they have these intermittent things, and the treatment is a low-salt diet and some diuretics, maybe some steroids in there as well from Meniere's. Ototoxic drugs, certainly they can accumulate and cause ototoxicity and give you vertigo. Not usually, because if you're taking an ototoxic drug, if I'm getting gentamicin, IV gent, why would it go to one ear more than the other ear, right? And we have three systems for figuring out balance, right? We have our visual cues, we have our otolith organs and our internal balance control from our inner ear, and then we have our peripheral proprioception, so we can feel. That's why we throw up for the Romberg, test. We throw off center of gravity. We put the hands out there to get the pronator drift test, but we throw off the center of gravity and then we close their eyes, right, to try to isolate that. And so usually ototoxic drugs don't cause vertigo, but they can. All right, eighth nerve lesions, absolutely. Tumors involving it, schwannomas, which I mentioned earlier. Tumors of the central pontine angle can do this as well. And so people may come in with ataxia as well with that. It's usually slower on onset because it's a slow-growing tumor, and so you get progressive symptoms. And then you get compression, and that's why I said the seventh nerve palsy that you can get. Now, if it's due to a schwannoma, we can't call it Bell palsy, because Bell palsy, to be pedantic, means idiopathic. And if you have a cause, it's not idiopathic, right? So if it's due to a schwannoma. And you may notice I say Bell instead of Bell's because Dr. Bell doesn't have the palsy, so it's Bell palsy instead of Bell's palsy. And then zoster. So you can get zoster oticus, and so that looks like a Bell palsy, but we don't call it a Bell's palsy. It's a peripheral nerve, seventh peripheral nerve palsy due to herpes zoster. And then, of course, the treatment for that would be one of the veers, acyclovir, gangcyclovir, valcyclovir, that type of stuff. That's peripheral, and we've been trying to differentiate that from central. So again, peripheral is usually intermittent, a burst, intense. If it's BPPV, it's got a delayed on onset when you put them in that head position. They get a horizontal nystagmus, maybe with a little bit of rotation, and then it fatigues, okay? As opposed to central, which is slow on onset, not so intermittent, usually consistent, and vertical. That's serious, okay? So there's lots of different causes. You can have vestibular insufficiency, multiple sclerosis because it's a demyelinating condition. Migraines actually can present like this, but if you've got nystagmus that's vertical in origin, you should be thinking central. So how can you diagnose this, especially if you're worried about a stroke? Well, the thing you can do is the Hintz exam, and again, there's lots of YouTube videos on the Hintz exam. Dr. David Newman Toker was the person who sort of really popularized this. He's a neurologist who runs a clinic that looks at this in particular, and is in his hands, the Hintz exam is more accurate, and that means sensitivity and specificity for positive likelihood ratios and negative likelihood ratios. It's better than an MR. In my hands, it's not. Okay? I am not David Newman Toker, and I don't run a vertigo clinic. All right? I'm a community emergency physician. Okay, so I take this old lady who's weak and dizzy with a kyphotic, osteophytic, osteoporotic neck, and then I do the hint, I suddenly turn her head. You know what we call that? A clean kill. If I was in grade 9 science, it would be called pithing, right? All right, so I'm a bit nervous about taking some, like this, with this, and just go, right? So that's the first part. That's the HI part, the head impulse, where you turn the head. I think that you really need, to get out your smartphone and have an app on it that can record the eye motions in super high speed so you can slow it down because it can be subtle and hard to pick up. But that's the HINTS exam where you take the head and you do the head impulse, you check for nystagmus, and then you do the test of skew where you put one hand over each eye and look for if the eye jumps from one side to the other, right? And there's always that guy that, I don't know, works in the lab or works in maintenance. Let's call him Jerry, and you're like, which eye am I supposed to look at? Which one, right? Because they may already have an eye that deviates, an exophoria, or trophia, which means it's always out. But you're looking for tests of skew, cover, uncover test, to see if that eye jumps back. All right, that's vertigo. Sinusitis, ugh. All right, x-rays are not required, so here they are. See that? Yep, no x-rays are required for this test, or for this diagnosis. Okay, so it's a clinical diagnosis, purulent nasal discharge. Sometimes the teeth hurt or you push on them, right, because the sinus is up here. But it can lead to badness. It can lead to a brain abscess. If you've got sinusitis and it leads to brain abscess, you're having a bad day. What is the causes? It's a bony thing. It's not a cartilage thing. Your sinuses, bone, right? Cartilage, Pseudomonas. Bone is the same as otitis media. In those little bones in there, in that little space, you get strep pneumo, H flu, and M catarrhalis. So that's how you can keep those straight. All right, and then, we've got x-rays and CTs showing a sinus filling up and being inflamed and thickened. Here's the complication, though. You can get orbital cellulitis, and how you tell the difference, orbital cellulitis versus periorbital cellulitis. If they put their eyes through their cardinal eye motions, the up, down, left, right, and that hurts, then you're thinking orbital. If it doesn't hurt so much, but they've got swelling and it's not quite as intense, you can be thinking periorbital cellulitis. All right, so eye motion should trigger you to think orbital cellulitis, much worse. That middle image is osteomyelitis. That forehead is actually bulging forward, and there's a little bit of light reflex there, that white light on the center of the forehead, because the forehead on that child is bulging out because of a sinus infection leading to osteomyelitis. And there's the brain abscess. Nosebleeds, we're experts at this, right? We've got lots of things in our toolbox. It's usually the Kesselbeck's plexus, the anterior part of the nose, right? TXA is now in vogue. We've got all these different ways to pack it and cauterize it. Back in the day, cocaine and epinephrine. I thought cocaine caused nosebleeds, but not only if you use it every once in a while to stop a nosebleed. But if you're using it all the time, it can lead to nosebleeds. The big problem is with posterior bleeds. That's much more serious, can cause airway obstruction and cause problems when you're trying to pack those things. Nasal fracture, this is the most common facial fracture that you get, and the history is quiet drink with a couple of friends, enjoying Chardonnay at book club, right? And this two guys just jumped out and popped me in the nose. Do you guys know what the most common broken bone is in the body? Billy Mallon does, because he does the ortho lectures. The clavicle, right? From birth to grave, womb to tomb, you can break your clavicle. But if you're talking facial bones, it's the nose, okay? And the concern is that you get an abscess, you get a hematoma. And if you get a hematoma, just like the ear, if you have blood and cartilage together, the cartilage loses, and you can end up with a deformity because of that blood on that cartilage. And then you can identify it through the old-fashioned technique of, ooh, look, on the pillow, a halo, right? That's one of the methods of checking for a CSF leak. And there's a nasal fractures on the left-hand side of your screen, showing some nasal fractures on some plain films. And then we've got the nose up in the air in the center, showing on the right-hand side the patient's left, right? They've got a nasal, they've got a septal hematoma. They need to be IND'd. They need to be drained. The little child down below, because it's on both sides, you could be confused and say he stuck 2 beads up his nose, which children do stick beads up his nose, but these are not beads up their nose. This is bilateral septal hematomas. And then, of course, there's the gentleman on the right having book club with friends in a Chardonnay. All right, saddle nose deformity. That's the result of if you don't do an IND on that septal hematoma. The concern is that you'll end up with this disfiguring situation. And you can see the gentleman on the right, not only does he have a saddle nose, but he also has a cauliflower ear. All right, midfacial fractures. So we've got a classification system for those, and you may need to know the Lefort classification. The Lefort classification from 1 to 3, with 1 being the mildest and 3 being the worst. It's sort of like the Salter-Harris classification that we have for kids and epiphyseal fractures in children, right? It goes from 1 to 5, with 5 being the worst and 1 being the mildest. Same thing here, 1 to 3. And so how I remember these is 1 is like a denture, right? It's like that upper plate that you could pull out, okay? Now, if you get a pyramid fracture, that's a Lefort 2, and you get a free floating, and now the nose is moving, right, when you pull on it, not just the teeth. And then if you get a Lefort 3, the whole face pulls forward when you put your thumb in there and you lift up. And I've got some pictures to show you of different Lefort fractures. The key is, though, if you've got a Lefort 2 or 3, that's a high-impact injury to do that kind of damage to your face, and you've got to be worried about other injuries like their C-spines and their airway. So there's a Lefort 1. You can see it's just like a dental plate, right, the top, okay? The nose is mobile in a Lefort 2, and the whole face, including the cheeks and the zygomatic arch, everything lifts up in a Lefort 3. So you got that? Lefort 1, 2, 3. Okay. Cavernous sinus thrombosis. This is a central facial infection that's bad. You get swelling of the eyes, eyelid proptosis, edema. You can get cranial nerve issues related to this. There's a whole bunch of anatomy that runs through the cavernous sinuses. And so here is a picture to show you. These are nerves. These are blood vessels. You get an infection in that blue space in there. You can see why it would cause badness in all those areas. So you'd be looking for cranial nerve 3, cranial nerve 4. You know what those do, right? Cranial nerve 6 is the most common, though. Okay, that's lateral rectus muscle in the eye, and so they may not be able to pull the eye to the side. All right? All right, let's go through some salivary gland problems. You can get viral infections and parotid glands. Mumps is the classic example. I have never seen a case of mumps. Fun fact, you can get increased amylase with the mumps, but I have not seen a case of the mumps. Has anybody here seen a case of the mumps? Yeah, it's just, universal health care and immunization and like immigration and stuff like that. Anyways, we just don't see mumps. Bacterial infections, below that, usually staph. Okay, so if you're thinking a mouth infection, a salivary gland infection, staph usually cause. And then you can get stones in there, right? Submandibular along here is the most common, and it's like, suck on some sour keys and see if you can get that out. Some lemons, try to get that juices flowing to expel it. But if the x-rays came with arrows, you can see the swollen duct and the little white spot showing the gland in the submandibular gland there. Sometimes you can actually just pick it out. And then this one is talking about the parotid duct and the facial nerve. And if you've got any kind of injury between the targus, which is here in the corner of the mouth, there's some badness in between with regards to the facial nerve and that parotid gland. And it's just a reminder to be concerned about any injury between the targus and the corner of the mouth. All right, so infectious mononucleosis, the kissing disease, Epstein-Barr virus. 95% of you guys have had it. Now, we know that some of them, some people just have like, I didn't feel well, I didn't go to school that day, and the next day I felt fine. And there's other people that miss a whole semester of school or miss a college year at age 18 because of this, and then everything in between. Key tip-offs for mono is if you look in the back of the throat and you do this, that looks gross, right? It's usually the worst case of strep throat you've seen, right? Because of all the exudate and stuff, and the glands are usually very, very swollen. So it's like, if you see a really bad case and you're like, that's the worst case of strep throat I've seen, think mono. Now, if you're not sure, check the anterior and posterior glands. Mono is more likely to have posterior cervical lymphadenopathy than anterior lymphadenopathy. But if you're still not sure, send them home with a prescription for amoxicillin. It's an in vivo experiment with an N of 1. And I learned that because, again, in my first year of residency in 95, I remember seeing a teenager come back. My supervisor assigned me this kid with a rash, and they had strep throat diagnosed, and they'd been given amoxicillin. And I said, they're allergic to amoxicillin. And I felt great shame. because that's when I learned about this, and that it's a pathognomonic rash that you can get. You don't see it with Pen V, but you see it with amoxicillin. All right, and then of course you can do a monospot test if you want, or you can look for those abnormal lymphs. Mononucleosis can affect a lot of different organ systems. The one thing that I'm worried about usually is, is the spleen and contact sports. But just a reminder that you can have a spontaneous rupture of your spleen. You don't have to be playing hockey or lacrosse or football or anything like that. You can spontaneously rupture your spleen. All right, we went from schwannomas, one of my ever favorite things to say, to Ludwig's angina. All right, and Ludwig's angina is this infection of the neck in the submandibular space, and people talk about seeing a woody neck, and I've got some pictures to show you of that. It's usually caused by dental infections historically, so bad dentition and bad, they were toothbrush penic, is that a word? Hypo-toothbrush, something like that. But the ones that I've been seeing is piercings, a lot of tongue piercing. And I'm seeing Ludwig's angina. That's the most common cause that I've seen, not so much dental stuff. You got to be worried about the airway in these things because they can occlude, and so you need to give them antibiotics, and it's usually, you need clindamycin and flagyl for these types of infections. And there are some pictures of that big red neck on 3 different individuals showing that Ludwig's angina. And then you've got acute necrotizing ulcerative gingivitis, or trench mouth, which is easier to say. And again, you get these bacterial infections of the gums. The trench mouth came from World War I, where dental hygiene wasn't the greatest during the war in the trench warfare, and a lot of young soldiers got this. It can be confused with acute leukemia, where they get proliferation of their gingiva, and also phenytoin can also cause this as well. Again, metronidazole and clindamycin to treat acute necrotizing ulcerative gingivitis. Lemierre's syndrome, we hear case reports about this. They present like a strep throat to begin with, but then it invades the superior superior jugular, and then drops down from the internal jugular, drops down into the heart, and the heart squirts those little emboli into the lungs, and they get really, really sick. And so we've got some chest x-rays and a CT scan showing Lemierre's syndrome, where they get these septic emboli to the lung. And so this would be the case history of a sore throat, and it started as a febrile sore throat, upper respiratory tract infection, and yet they come in looking quite toxic with respiratory symptoms. You've got to be worried about Lemierre's. Peritonsillar abscess, this is the most common deep facial infection in adults. We don't see it in little kids that often, and they don't present like strep throat. They present with unilateral. Sometimes they have the hot potato voice and talk funny. Because of that swelling, it's rarely bilateral. There's some information now coming out saying, can we manage these individuals with clindamycin or something like that and dexamethasone and follow them clinically? Still, the standard approach is it's an abscess, we need to IND it, we need to drain it. One of the ways to make it a bit easier to decide is there something to drain there is if you're getting quite proficient with your bedside ultrasound, your POCUS. You can ultrasound these. Now, you do it internally, you don't do it externally, and you don't tell the 13-year-old boy that it's the vag probe, okay? It just doesn't go over well. I'm telling you all the mistakes I've made, right? I'm just going to use this endoscopic probe to look at the back of your throat, and then aspirate it. And there are some examples of peritonsillar abscess. The one in the bottom right-hand corner has 2 arrows showing that it's bilateral, but that is rare. It's usually more like the one right above it, where it's on the one side pushing the uvula over. And then on the bottom left-hand side, they've got a needle drainage going on. Retropharyngeal abscesses. These are little kids that are really sick with fever and neck pain, and they talk about a duck-like voice. That's cri de canard. Cri de canard. They quack. Okay, it's not croup. It's not barking. Okay, it's talking like a duck. All right, and what you do is you get a soft tissue view of the neck, X-ray to start with, and you can move on to CT, but the soft tissue view would be the first spot to start. But these are sick kids. And if their radiologists are really nice, they put dots and arrows for you. And if you haven't seen a lot of soft tissue views of the neck, hopefully you can look at that and go, that's a lot of swelling. I mean, I know from traumatic ones, you know how they go, okay, so it's 6 millimeters at C2 and 22 millimeters at C6. I remember that from trauma, right? Looking at, space, right? That's a lot of space. That's a retropharyngeal abscess. That's badness. That's airway obstructing. That's admission, antibiotics, consults. Diphtheria. Anybody seen diphtheria? I've never seen diphtheria. Okay, the key to that is they get this pharyngeal pseudomembranous forms, these white plaques that don't look like yeast, right? They don't look like thrush on the back of the throat, and they're right on the tonsillar pillars there. And they've got this thick membranous thing, and it's an exotoxin that causes necrosis there. And I've got a picture of it. And so it can be bad. Diphtheria can be bad, can cause myocarditis, cause airway obstruction. The treatment is, of course, prevention, so obviously immunization, but then erythromycin or penicillins to the carriers as well. And so there's some pictures. So if you get a picture of somebody's back of the throat and they say, what do you think that thing is on the back of the throat? It's not a Q-tip, it's not thrush, it's a pseudomembrane from diphtheria. Okay, and it can cause some swelling in the neck as well. Looks like Ludwig's angina, but look back there and you'll see that pseudomembranous thing, and that's the tip-off that you're dealing with diphtheria. Bacterial tracheitis is the worst case of croup you'll ever see. So they're much more toxic looking. It's life-threatening in these children. They're severely sick. It's usually staph, H flu, and these need to be admitted, IV antibiotics, and followed. But bacterial tracheitis. But they do present like the worst case of croup. Very sick, very barky, stridor, that kind of stuff. Epiglottitis, I've only seen cases in adults. Who's here seen a kid? Oh, I almost had you there, didn't I? Almost. Trick question. Yeah, I've only seen it in adults. I haven't seen it in children because of, the huge immunization with the non-typable or H flu that came through. But my older colleagues tell me that they would come into a room and see a child tripoding and drooling and quiet, and it was like, whoop, sphincter tone just went up, because that's going to be a difficult case with epiglottitis. The last case I saw was an older individual in their 70s, and they'd been put in fast track, like most serious cases. And isn't that happening, you guys? You go in there, and it's like they walked in, they're fine, and they've got a C-spine injury. Just because you walked in doesn't mean you didn't break your neck. So this person was, sore throat or something like that. You go to, I'm finishing up my shift, right? It's that last hour. You're winding down. You're finishing some charts, getting rid of some other things, and just going to pick up a few non-urgents and fast track, help flow. And it turns out to be a man who starts writing notes to me when I walk in the room. I'm like, oh, crap. I look in the back of the throat. What do I see? Nothing, of course, right? Because it's lower than that. The epiglottis is down here. So I'm like, I think we need to move you to the other side of the department. Come on with me, sir. And then, of course, yes, that's exactly what he had, epiglottitis. So one of the tip-offs was I did that little handshake with him where I moved that cartilage there, and he went, ow, and I went, okay, we're moving. That was my tip-off. When I looked, and he was writing notes because he couldn't speak because it was too painful, and then I moved his thyroid cartilage, and he went, ow, and we went out. That's your ENT. X-ray, you can get that thumbprint. You don't usually see the thumbprint as dramatic as in children. It's more a diffuse, generalized swelling in the adult population, but that thumbprint is that classic, and we've got a picture for you to show you. Ceftriaxone, sure. Oxygen if they're hypoxic, yes. Steroids, I gave steroids, and in fact, when I consulted my ENT colleagues, they said give them epinephrine. Right, racemic epinephrine for nebulized to bring that swelling down. And my question back to them, and trying not to be flippant, was, yes, I told you he was in his 70s, has a history of coronary artery disease, febrile, and has a heart rate of 120. What dose of epinephrine do you think I should use, doctor? I shouldn't have said doctor probably at the end, but anyways. So there's your enlarged epiglottis with a nice arrow sign. He has a positive arrow sign, so it's easier to pick. I think the one on the left-hand side has the more diffuse. It doesn't look exactly like a thumbprint, where the one on the right with the arrow shows that thumbprint more clearly. Croup, these are the Barkers, right? 6 months to 6 years, parainfluenza virus, and this is the diagnosis from triage. You hear them and you hear this kid going, and you're like, that's croup, 0.1 to 0.6 milligrams per kilogram of dexamethasone orally, we're done. They've done the dosing studies on that. Yes, you can use epinephrine if they're sicker. They do not need antibiotics. This is a viral infection. All right, when we talk about the mandible now, trismus, we've got a date mnemonic for dystonia. Abscess, so peritonsillar abscess can do this. Ludwig's angina can give this. Tetanus, so tetany, and epiglottitis. And then mandible fractures, you get into malocclusions. You know, if they have TMJ pain on both sides with a direct blow, you're worried about mandible fractures. And in children, you've got to be more worried about mandible fractures because they've got growth potential, and that might be more serious than just an adult with a mandible fracture. Yeast. Like you guys know thrush, right? Like that's pretty easy. That's yeast, right? And you know the risk factors, the steroids, immunosuppression, taking antibiotics recently, dentures, HIV, chemotherapy, and you treat it with clotrimazole. Leukoplasia is different though. It doesn't show up as well, does it? It's these white spots that almost look like plaques, not as dramatic as this, and this can be a precursor to cancer. And you see it in smokers. And so the tip-off here is if they're trying to fool you with a case like this, try and lead you down the thrush route, but they don't give you any of those high risk factors, and they say they're a smoker and they've got that, that's a biopsy, that's an oral cancer, potentially, and so it needs to be biopsied. Canker sores, yep. All right, herpes simplex. Herpes simplex, fever blisters, HSV 1 or 2, risk factors involve graduation, photo day at school, and weddings. That's when you get herpes, right? Anyways, you guys know this, and for bad attacks and first attacks and stuff like that, it can happen anywhere between the nasolabial folds, right? Anywhere in the nasal, from the nose to the nasolabial folds, the marionette lines, and down to the chin. So anywhere right here, you can get that. And you treat it with antivirals. Herp angina, though, is different. So different. And it's different than strep throat. Herp angina is a Coxsackie virus that we see in the summer, right? In children usually. And you look back in their palate there and you see these little vesicles, these little lesions back there. It's really classic. And it spares the buccal mucosa, whereas this is all about the buccal, right? It's all about right in the lips and stuff like that, and moving away from the lips. This is in the back of the throat, self-limiting, viral illness, Coxsackie virus, easy. Supportive management. Dental caries. I'm going to go through dental caries, or all the dental stuff. I play dentist nights, weekends, and holidays like you do. And so it's pretty simple. It's a trifecta of things. It's pain control, so P, right? Pain control, antibiotics usually, and refer to a dentist. So PAD as far as I'm concerned. Adequate pain control, some antibiotics, and refer to a dentist. So we've got reversible and irreversible pulpitis. Worse with cold temperature is the reversible one. Irreversible is worse with hot temperatures. I don't know how you're going to remember this. I have my own little tricks on how to remember it, but reversible is cold temperature. I'm from Canada. This cold shall pass. It's reversible, but that's how I remember it. Irreversible, it's always there, and it's worse with hot. Maybe think Arizona. I don't know. And then the treatment, adequate pain control, and antibiotics, and refer. Then dental abscesses. You guys are probably dental abscess experts. There's periapical and periodontal. The periapical are the ones right at the tip, at the root. They're the most common, and the periodontal ones are the ones when they open their mouth and you see on the side, and it's like, ooh, I just want to pop that big zit on the side of their mouth. That's the periodontal ones. Again, it's adequate pain control, antibiotics, and sometimes you have to add in flagyl or metronidazole to that. Clindamycin and metronidazole, sometimes just plain amoxicillin or penicillin isn't enough, depending on them, and refer to dentist. And there they've got some pictures of the periodontal ones around the side. You could see you could just nick that. The periapical ones you can't get to. They're at the roof. Now, people do dental blocks and things like that. Fine. It's not what we're talking about. But referring to the dentist is more definitive after some antibiotics and pain control. Alveolar osteitis, I had this during my residency. Of course I did. I was on my orthopedic service at the time. So, you know, like, oh, hey, I've got like lots of health coverage. I think I'll go get my teeth pulled and get my wisdom teeth pulled. And I ended up with dry socket. And of course, you know, I'm taking Tylenol 3s, so I'm constipated, I'm dehydrated, I've got codeine on board, I'm covered in like surgical garb, and I fainted. That was the second time I fainted. I told you about my first faint. The second time I fainted was in the OR, and they're like, oh my God, he's such a wimp. And meanwhile, I had alveolar osteitis because I had my wisdom tooth, all of them, pulled 2 or 3 days later. The mask hid the chipmunk cheeks. And so the treatment is, you know, you pack it, you get them on some antibiotics, adequate pain control, and get them back to the dentist. Maybe I'll tell you the third time I fainted. I'll save that for tomorrow morning. I've only fainted 3 times. That involved EMG testing. All right, so avulsed teeth, get them back in as soon as you can, except if they're primary teeth. You know where they go? The tooth fairy. Okay, and all these people come running in, oh my God, oh my God, oh my God, the tooth fairy. You know, it's like, it's not a permanent tooth under the pillow. I don't know how much money you get for it, but that's where non-permanent teeth go. Permanent teeth, that's the emergency. We've got 1%, loss per minute. Okay, that's an estimate, but time is tooth, and so you want to get that back in there as soon as possible. People talk about keeping it in their buccal mucosa, in their own saliva, throw it in milk as the old way of saying it, and you bring it in there and you push it back up. Try not to brush it off too much, just rinse it off gently and replace it. And there's a picture of an avulsed tooth and some dental fracture stuff. And there's a whole bunch of information on dental emergencies. The type is really small. If you want to go through that and review that on your way home or sitting in the airport, just to consolidate your knowledge. But again, with most dental stuff, it's adequate pain control, and that can be everything from NSAIDs to opioids, because they can be very painful. So for a short course, appropriate antibiotics based on the clinical situation, and a referral to a dentist. Neck masses. Okay, so infant, child, young adult, and adults. I don't know if that really helps us differentiate, but hemangiomas, lymphangiomas, brachial clefts for the infants. Now you'll get thyroglossal cysts, which are central because right there, but brachial are over to the side. Young adults, if you see a lot of lymphadenopathy, you're thinking strep throat. If it's anterior, if it's posterior, you're thinking mono. And then if you get an adult with a mass in their neck that's there and it's painless, it's a tumor until proven otherwise. And there's just a whole bunch of pictures of different masses for you to consolidate your knowledge, everything from abscesses to cysts. All right, facial nerve palsy. All right, so you know, when it comes to peripheral nerve palsies and stuff like that, I always have to go, okay, does the forehead move or not? Like, does it go up or not? And I always have to rethink that through. But if it's peripheral and you've got an idiopathic, or what we refer to as Bell palsy, right, the whole side of the face, the forehead, the frontalis is also involved. So you get them to raise their eyebrows up, and if they can raise their eyebrows up, but this part droops, you're thinking stroke, right? And usually people come in, and it's usually not them that noticed, it's somebody else noticed. It's like they woke up, they went to work, and then somebody says, what's wrong with your face? Right? And they're like, nothing. And then they go look in the mirror, and it's starting to droop, right? And then the alarm bells go off, and we send them in for stroke protocol, right? If the CT ambulance arrives first, and then we push, no, I'm not going to push the TPA. But it's a peripheral nerve. It's not a central origin. Now, if both sides of the forehead move up, you're thinking stroke. If one side is down and the other side moves up, it's a Bell's. The only time I've been confused is when both sides of the forehead couldn't move and this was down. And I'm like, wait a minute, it's not a stroke, it's not Bell's. Yeah, and the woman leaned into me and said, Botox. And I understood why both sides of her forehead would not elevate. All right, peripheral toxin. All right, so steroids, you can say plus or minus antivirals. The data flips back and forth on that, but steroids are the mainstay. Tape the eye shut so it doesn't get damaged. Herpes zoster oticus is not a Bell palsy, it's a peripheral nerve palsy, but it has a cause, so it's due to a herpes zoster, and this, of course, mimics the 7th nerve palsy, but they get the rash, right? They get the herpetic rash, and so you see that zoster, you see that shingle. And so you use acyclovir drugs. And there's a picture of Ramsay Hunt. Ramsay Hunt, that picture on the lower right looks exactly the same in Bell palsy, except they get the rash, right? And so that's why you do steroids and antivirals, for sure, in Ramsay Hunt. Herpes zoster ophthalmicus, we discussed this earlier in the day with the Hutchinson sign on the tip of the nose and affecting the cornea. You can stain the cornea up and look for dendrites, and you're giving acyclovir-like drugs. Tongue angioedema, coming like this, and you go, oh my God, that's going to be a difficult intubation, right? There's the idiopathic ones, there's the hereditary ones for angioedema, and then there's the ACE inhibitor angioedema. I think the ACE inhibitor is the easiest one because you just stop it and observe them. I don't blame people for throwing, steroids and antihistamines and things like that at these people, because often when they come in, we're not sure exactly what it is, and it can look very allergic. Now, they do have, for the ACE inhibitor angioedema, it's just remove the ACE inhibitor and follow them clinically. With the hereditary, they of course do have some treatments. Icatibant is the most effective treatment, but you can also use fresh frozen plasma for that. Now, they did try the icatibant for the ACE inhibitor angioedema. It's very expensive, so my P&T committee said, for using icatibant, they said icatibant. You can't use that. And so that's how I remember that, because it doesn't work for the ACE inhibitor angioedema. Strawberry tongue, strep throat with a rash. Okay? So if you get scarlet fever, it's strep throat with a rash. They get a strawberry tongue, they get the pasta lines in the flexor compartments, right, on the skin folds and things like that. Antibiotics is penicillin. It's just scarlet fever is strep throat with a rash and a strawberry tongue. Streptococcal pharyngitis, yes, you can go through the Centaur criteria. Temperature greater than 38 degrees Celsius, anterior cervical nodes greater than 1 centimeter in the anterior chain, absence of cough, and exudate and tonsillar swelling. If you have all 4 antibiotics, if you have less than that, you're supposed to be swabbing. Key fact is glomerulonephritis can't be prevented with antibiotics in these cases, and also peritonsillar abscesses do not present like strep throat. It's usually unilateral. And the other thing is, what about rheumatic fever? The adult literature shows that you have to give 1 million prescriptions. The number needed to treat is 1 million to prevent 1 case of rheumatic fever in adults. We still treat the children more often with the antibiotics, but with the adults, 1 million prescriptions, and only 1/3 of those people will go on to have consequences because of the rheumatic fever causing a valve problem. Only 1/3 get a valve problem. So really the number needed to treat for a clinical problem due to that is 3 million. But I know people are still giving antibiotics to adults. Dexamethasone works quicker and faster. I usually use shared decision making for this in adults, not in children. Peritonsillectomy bleeding, they usually happen about 5 to 10 days. So it's usually a week after they've had their tonsils taken out. You can put direct pressure back there. You can put epinephrine back there. You can put TXA back there. But I think what you need to put back there is an ENT doc. That's what I do. I go, yeah, you took out their tonsils last week. Yeah, they're bleeding. Yeah, okay, bye. They're usually pretty good about it. And then uvular edema or Quincke syndrome, and that's your uvula getting really swollen. We've got a picture of a piercing there. You can give them some Dex for that to bring down the swelling. Causes angioedema there. Uvular edema. And the last thing, esophageal foreign bodies. The esophageal foreign bodies, the key for this is in children, we've got to really make sure it's not a button, and they can have a step off, so it doesn't look like they swallowed a dime and a nickel, and they stuck together in perfect symmetry and went down together. All right, that's a button battery, and that can eat through tissue very quickly because of the arc it creates with the electrical current, and so those need to be removed quickly. They used to say that, like the child would just poop it out and make change, not for button batteries. So you got to make sure that it isn't a button battery, and that step off on the x-ray will show you whether or not it is.